Hello, everybody, and welcome to the National Healthcare for the Homeless Council's COVID-19 Town Hall Series. Today, we are talking about avoiding civil detention and responding to clients who violate isolation orders. My name is Barbara DePietro. I'm the Senior Policy Director, and I'll be moderating today's discussion. Just want to do a quick orientation to the issue that we're all grappling with right now. As we know, there's a number of communities that are setting up alternate care sites in congregate and non-congregate settings. These are coming together very quickly, and a lot of folks who are experiencing homelessness and need isolation and quarantine are being put in these new settings. And these settings are delivering a wide range of services, some being very robust, but some not really delivering many services at all. And then the types of providers or the workforce that are delivering that support are also really wide-ranging. And many of them may not have a long experience with serving people experiencing homelessness. And so this might be a new population that people are being asked to support. We also are understanding that many of these alternate care sites, varying levels of admission criteria. The program rules look very different. And so when we're asking people experiencing homelessness who bring a lot of medically complex issues, obviously everyone is under a lot of pressure right now. There's a lot of uncertainty. And so the environment for being stressed out and escalated is really, really common. And so this just creates a challenging situation on how do we best support very vulnerable people in these programs. And in particular, for the challenging folks who may have really particular vulnerabilities, maintaining isolation, a strict isolation may be really hard. And so how can we as service providers avoid negative consequences like civil detention or involuntary commitment? And how do we just adopt some strategies to better support folks that have got some special challenges? So just that was just kind of to set the stage for what we're talking about today. And then here, let's just talk a little bit about how today will go. So the goals here today are to talk about the current challenges we're all facing, to hear how other people are addressing this issue. We've got a great lineup of speakers, but we also have a really active chat box here. And so a lot of this discussion is really about all of us and what we have to offer. I think all of us have got questions, but we also have ideas and strategies and resources that we're using too. So I think in this really busy environment right now, we're just all trying to figure out how do we get our hands on the best information and be able to operationalize that as quick as possible. And so one of the things I want to do just from a technical perspective, you'll see a chat box down at the bottom, and this is where our coffee chat will be happening. So be putting in your questions, your ideas. We're going to have a running discussion with our panelists today, but we're going to be drawing on the questions that you submit in the chat box, as well as drawing on the questions that were submitted ahead of time. And also everyone should know that everything that you type into the chat box will be seen by everyone. And if you're having any problems at all, you can give, we can also answer some technical issues in the chat box, or you can give us a call at 615-200-6165, and Caroline Gumpenberger will help you. So with that, also wanted to make sure that everyone understood that today's presentation is being recorded, and it will be uploaded, and it will be emailed, will be emailed directly to anyone who registered. So I think that is all of the logistics, and so why don't we plunge in? Oh, one more thing, just wanted to make sure, while today's discussion will not be exclusive to people who use drugs, we do understand that substance use disorders do create challenging situations. So we do have a new guide out, an issue brief that's aimed at alternate care sites, talks a little bit about harm reduction and why that's so important, and then it really outlines some programmatic and policy strategies that you might consider adopting in your program so that you can make this an easier space for people to successfully navigate. And then it also contains some links to additional resources. Down in the resources box, you will see that the issue brief is linked there, so you can just directly access that. And so, well, getting to the good parts here. So we have some really great folks to talk with us today. From Yakima Neighborhood Health Services in Yakima, Washington, we have Rhonda Hauff, who many of you may know is the Chief Operating Officer and Deputy CEO, and then Annette Rodriguez, who is their Homeless Services Director. And then from Bethlehem Haven in Pittsburgh, we have Dr. Sharon Higginbotham, who's the Chief Operating Officer, and John Strong, who is the Shelter and Residential Support Staff Supervisor. So I so appreciate the four of you being here today with us, just to talk through the challenges in isolation, the strategies that you have found successful, and to help facilitate this conversation today with, right now we've got about 260 people who have joined us and are obviously interested in figuring this out with us. And so with that, what I'll do is I'll just open up with our first question, and this will be for Yakima. Can you just characterize what a typical day looks like for you and maybe introduce yourself and your program a little bit?
Sure. Hi, Barbara. Thank you. This is Rhonda Hauff. And normally when we start introducing ourselves, we start with a beautiful picture of the Yakima County, which is agricultural in nature. We're right in the middle of the Pacific Northwest, and so you see usually our bounty of apples and our harvest. But this was actually the front page of our local paper yesterday. This is us, the dark green blotch showing that we have twice the state average of COVID-19 right now. So this week, it's not always true that we can say that an apple a day keeps the doctor away. So that's our story this week. Yakima Neighborhood Health Services, we're a community health center. We also have supportive housing for about 80 individuals and families. And we have a medical recuperative respite program that cares for 10 to 15 individuals. And we're in the process of building a third project that will house another 5 people, hopefully open in the next month or so that we'll be able to accommodate suspected or positive COVID patients. For this discussion, we're really focusing on our chronically homeless in our most congregate housing facility and in our medical respite programs. So our supportive housing programs house up to about 40 people. They are individual dwelling units with bunk beds for 2 unrelated people and some family units that house 2 to 5 people. And a dwelling unit basically is a bedroom, and 4 to 5 dwelling units share a common bathroom and a kitchenette. There are 2 large common areas, one for the public and one that has shared activities. There's one area for the residents and the guests, and then there's one area that is just for the residents alone. There's like large big screen TVs that people share, and then other areas, the other areas for our case managers and behavioral health staff. It also has computers and a reading library. In our medical respite program, those are typically, the one unit is 2 separate facilities dedicated with one building that has individual bedrooms and bathrooms, and those will be for our COVID positive patients. And then another building that is for the non-COVID patients that's more shared, a congregate, individual bedrooms, but with a common sleeping area. And when the third building is complete in early June, we'll decide where the greatest need is, whether it's for the COVID or the non-COVID patients. Our challenge with isolation and quarantine are really the same with both our housing programs and our respite programs. The idea of social isolation and distancing is crazy to some of our clients who have spent years building a community in a pup tent or under a shade tree to protect themselves from the elements. So when we implemented our shelter-in-place orders from the governor, it was a really heavy lift for our staff. We still haven't met anyone who really wanted to be homeless. The issue is what people are asked to give up in order to accept housing. And so we knew that that was going to be our greatest challenge, whether it was for our patients that were sheltered, unsheltered, our patients in our homeless, in our primary care clinics or whatever. So our best strategies have been to use our relationships with the staff, between our staff and our residents or our patients, And then to combine that with our trainings in housing first, harm reduction, and our motivational interviewing to keep the clients engaged, to keep them safe, and most importantly, to keep them housed. So what have we done so far? We've restricted visitors from our housing and respite units. We take their temperatures every day. We've added activities. We've added to the reading library. We've started box gardens to try to increase other available activities. We have video libraries and things like that. We've also rotated some of our case managers to sites to find the right personalities for the right units, making sure that they had the right skill sets to connect with the residents and patients that they're working with. We've really learned that it's all about the relationships. We've also increased our nursing time and behavioral health services time at those sites, providing one-on-one meetings and group sessions about COVID. And what we found is that most all of our residents have heard of COVID-19, but most of our folks really didn't know what it was and how it can hurt them. And you can show the next slide, please. So this is just a screenshot. On the left, you'll see this is the common room in one of our congregate facilities. Sydney on the left is got some handouts that basically on what is COVID and how to protect yourself. Everybody in our respite and housing facilities, we have a universal masking protocol. And in this unit that they're in has about 30 residents in it now, but we're going through over 100 masks a day for them because people, as they do come and go, they tend to lose them during the course of the day. And so this is one of those days that what I refer to as calling a full court press. We're sending our A-team in to really talk about the importance of masking and hygiene and washing hands. We put in a lot of additional hand sanitizers throughout the facilities, and food is always a motivator. So one of our local Rotary clubs actually donated about 75 box lunches from a local restaurant. And so she and Robin, one of our case managers, were spent a good part of a day there talking about the importance of self-isolation and talked about what it meant to them and their friends. It's crazy that some of these people are the most vulnerable. They have lots of mental health needs, lots of physical disabilities, but they still think they're the most invincible. On the right is a picture of a park that is just about a block away, less than a block away from the housing program. And this is one of our greatest challenges because many of our residents that live in DRDH, this housing program, came when they were unsheltered, came from staying in this park. And so it is a huge magnet for the people that live in the housing program to want to come back and forth to this park. And so this is one of our kind of greatest challenges that we're working on right now through the engagement with these residents. So I'll stop right there for this question.
Got it. All right, well, thank you. And Dr. H. or John, would you like to talk a little bit about what a typical day looks like at your program? You might be on mute. I can't hear you.
I am on mute. Thank you.
Okay.
I'm sorry. John and I both are going to, we're both going to share here. If you look at the screen, you can see our temperature taking station, and you can see the front desk now, which has protective glass on it. And we've made very similar measures that Washington has made. And so when you come into our building, everyone has to take their temperature. We have a checkoff sheet for staff because we want everybody's temperature to be taken. If they are 100.4 or more, you know, we will call our medical director and then take it from there. So in shelter, we have 28 beds in shelter, and we serve only women in shelter who are both mentally ill and abuse substances. And so what we have seen, what's been very interesting, is the shelter beds for the first, I would say, first 3 weeks, John, we had like maybe 7 clients in shelter. We also at that time really housed about 8 clients, you know, coming out of shelter. So it's been very interesting to watch because, of course, you know, we have to make sure that we're protecting folks. One of the things that we've done is we have split up the beds. So we have another building, which is our 1410 building, which houses 26 residential permanent supportive housing people, and so that we could get 6 inches so that the women could sleep. We have some of those folks are up at our other building. The other thing that we've done in all of our programs is we've staggered meals. Certainly we have revamped our meals. We've gone from kind of a family style to now we have ordered individually wrapped meals. We've ordered individual milk, all of those kinds of things. We also have a medical respite program, which has 29 clients, or 29 beds. We have 20 clients at this time. And one of the major things that we did with regard to medical respite and COVID is we have 3 isolation rooms. So most of our referrals come from 2 hospital systems here in Pittsburgh. And so if we get a client, a referral from the hospital, and the client you know, has not been tested, we will put them just in isolation just to make sure that, you know, their fever is good, that they don't have a cough, and we take temperatures and that kind of thing. And if there's any spikes, then we would, again, call the medical director and then get them tested. We've had, I think, 3 or 4 people in isolation in the last few weeks, and we have had all negative comebacks. We also have 60 community beds in the program, and so with regard to all of the folks who are on site, our challenge is keeping people distanced and to wear the masks because, as you know, when you have medical respite, those folks are already compromised. One of the other things that we're seeing, one of the pieces that we have in our respite program, so we have a medical side and then we have a social services side. The social services side is focused on getting people housed. We would prefer not, we would really love not to send people to shelter or to back to the street, because we know that housing really is health, and so we work very hard to get people housed. What's been very interesting, though, is landlords are putting folks on hold. Some of the permanent supportive housing programs have everything on hold, so we're getting pretty full here in respite with regard to having beds available for others. John, do you have anything to add?
Yes, I would say that, like Dr. Higginbotham mentioned, our biggest challenge now is encouraging clients to maintain social distance, wear their masks, and most importantly, to shelter in place. Pennsylvania's governor shelter-in-place order did allow people to go outside to exercise, and we are finding a lot of our clients using that as an out. In other words, I would like to go for a walk, and we encourage them that it's probably not the best idea to be out and about in the community, but we really can't stop them. So, you know, then they come back to the congregate setting that is shelter, and you know, that endangers staff and other clients, and that is our biggest challenge, I think, is that, we have no idea what people are bringing back into the congregate setting in regard to COVID-19.
Got it. All right, well, thank you for that overview. I think that kind of gives us a bit of a sense of what you've got going on. One of the things that I want to come back to is an oversight on my part. We have so many people that have joined us. We're now over 300 folks that have joined us for this conference. We want to learn a little bit more about who's joining us, though, for this conversation so we can tailor some of the responses. And so Brandon De La Cruz, who is our technical extraordinaire, will bring up a poll question. And if folks, as you are sitting at your computer, if you can just tell us a little bit about which category you might be fitting into, just so that we have a sense of it. And there may be health center or HCH clinical folks, health center or HCH administrative folks. You may be coming from or staff with isolation and quarantine programs or alternate care sites. Maybe there's local government or public agency staff that are coming and figuring this out too. I know we've got a lot of policy, research, and advocacy folks who are interested in this. And then there may be tons of folks who fall into the other category. So we'll just leave this up for another minute, but just trying to get a sense of who's with us. And so it does look like most folks are falling into the other category. It's been very hard, I think, in this COVID environment to know there's so many new folks who are coming into this space of homeless services. And so really appreciate if this is something that you've not joined us for in the past. Really excited that you're here for this conversation. At this point, Brandon, I think we've got kind of a snapshot of what about a little over a quarter of folks from local government or public agencies, about half falling in other, just shy of that, 10% HCH or health center clinical. Okay, thank you very much for that. And then we will go on. So we will pick up some of our questions and just keep this conversation going. So why don't we start back with Yakima, and could you describe a recent specific client who has posed a challenging scenario for you and how you responded to that?
You want to do that?
Hi, Barbara. This is Annette. So I'm going to share a story, and I'm going to change the name for obvious reasons. So we're going to call this gentleman Sammy, and he is somebody that we've known for a very long time, just recently housed, living on the street for the past 4 years. Fairly young individual, mid-20s. So Sammy was housed at our congregate living facility and was frequenting, coming in and out of the building. And after the stay-home and shelter-in-place came out, it was really hard to get him to understand the importance of his coming and goings. Because he was recently housed and still had lots of friends and he calls family out on the street. And so staying home and staying safe for him was pretty important to also be with his friends out on the street. And so one of the things after our case managers had conversations with him was that he decided that it was that he was just going to kick himself out of housing. That was just what was important to him, was to be out at the park, which Rhonda described as just a few blocks away, actually. But those were his friends, those were his family, and he wanted to be with them. And so he called it, "I'm kicking myself out," because he didn't want to shelter in place, and he basically just said, "I'm going to take my things, my belongings, and I'm going to pack my bags, and I'm going and I'm moving out." So the case manager walked with him through this whole process and kept emphasizing that this really didn't have to happen, and what else could we do to help him, make it easier for him while he was sheltering in place. But he wasn't going to have it. He was being pretty set in his way that day, and he decided to leave. Well, in our community, we also have we have ordinances in our community, probably very similar to some, that there is no camping in the park, there's no encampments or setting up tents in the park. And the park that he ended up at that very next morning, the local law enforcement were basically doing their sweeps or their runs-throughs, offering folks to either go to shelter or go to jail. I mean, that's what their options are in our community. And if there's shelter available, they would be willing to take them to shelter. Well, Sammy started explaining to the officer who we also, like Rhonda mentioned, relationship is really important, not only with the participants that we're working with, but also with our local law enforcement. And because of that, the law enforcement officer that was working with Sammy that day actually came over and talked to the case managers to see if there was something that they could work out, because Sammy had explained to him that he basically had kicked himself out of housing. He wasn't sure if he could come back. He hadn't had those kind of conversations, and he was open and willing and thought that maybe that was a better option for him if the officer could arrange for him to get reconnected to the case manager. And so that's what happened. That very next day, the officer with Sammy and the case manager talked about the importance of him staying home and keeping safe, and that it was important for him because, while he's housed, he has access to, running warm water and a place to wash his hands and a place to isolate himself and protect himself. But not only that, but protect the people that he has relationships with, like his case managers and some of the neighbors that he's gotten to know in the building. And so Sammy thought that was a really great option, and also was interested in finding out ways to be more active. So one of the things that we do also is we do have computers that they can access in our building so that they can stay connected to families and friends as well. So they have access to that. Sammy was also interested in doing a garden, so he's really excited that there's that we have the garden boxes in place. And one of the things that we thought was really kind of cool was that on his way, because the case manager, like we said, is really close, the park to our building, walked him back to go back to his housing because it was all agreeable. There was no reason Sammy had to leave our building. He had exited. But one of the things that Sammy did when he turned around and looked at his friends, because he went to say goodbye, he hollered at them and said, "I'll see you in 30 days." So we thought that was kind of cool because he was understanding what message we were trying to drive into him about the staying home and stay shelter in place. So that was really cool, and we thought that if we could get through Sammy, that it would be a lot easier to get through everybody else, because now we had an example, and he lived by example. The very next day, he looked amazing. He was happy. He was glad to be home, and he is still home. So he was a challenge, but we got through it, and it just opened more opportunities for us to bring our nurse in and our behavioral health team to have more conversations with the whole with the folks that are housed there. So we thought that was pretty cool.
Great. Well, thank you, Annette. And John, I think you have an example of a client that has been challenging for you that we can just describe fairly briefly, and that way we'll be able to get to a number of questions that have come in.
Sure. Yeah, sure. So in Allegheny County, where Pittsburgh is located, they have actually opened a safe haven hotel for individuals who are at risk, symptomatic, and or positive. We had a number of our clients at the shelter who fell into the at-risk category. In other words, 60 years of age or older, and chronic health conditions. One client in particular was in her mid-60s, had COPD, and is smoking tobacco. So she was at significant risk, living in a congregate setting such as the shelter. And I made the referral for her to be transferred to the Safe Haven Hotel. She was agreeable at first, but then when she realized that she would have to be basically isolated / quarantined there, she was hesitant to go there, and she ended up going, but then immediately wanted to come back to shelter. And it took me to go out to the hotel and talk to her and try and reframe it in a way that made her think about her long-term safety, and to have her think about it. She may be uncomfortable at the hotel because she has to stay there and isn't allowed to move about freely, but I asked her to think about it. It might be a few weeks, it might be a couple of months, but that trade-off is better than testing positive or getting COVID-19 and possibly dying here at the congregate setting. So, it was a difficult conversation. She did not want to stay there at the hotel, but I finally was able to convince her, and now she's been there a couple of weeks. We check in with her about every other day, and she seems to be settling in and is, I'm thankful that I feel like she's in a much safer environment there than at the shelter.
That's great. Thank you, John. So let's go to a question that we had gotten submitted in advance. What are the best practices pertaining to people with serious mental illnesses who may lack insight that they have SMI and therefore aren't seeking treatment or help? Where do they go and how do we respond to them? And so I'm thinking about putting this in the context of isolation and quarantine, people who have significant mental health issues and may not be in treatment. Curious, maybe we want to start with Yakima. Rhonda or Annette, do you have any responses to a question on how best to support people with SMI? With SMI, serious mental illness.
Thank you. Annette, do you want to start? Do you have thoughts to start with on this? Are you muted?
Can you hear me? I'm here. Yes.
Yes,
I guess when I think about that, I definitely think about it as probably our biggest challenge. The most important thing is to make sure that you get the behavioral health involved on the team. We work really hard with our behavioral health to be part of our care team with that individual so that the relationship is there. We honestly, in our area, I really feel we're getting through because of the kind of responses that we're getting from our community that are dealing with severe mental illness. The kind of things that they're asking for us is things like, well, basically the things that they need. They notice that there's less transportation going on because of the whole sheltering in place. They're asking for sanitizer and they're asking for masks. So, and these are individuals that we know are suffering with severe mental illness, and so giving them flyers and handouts. Some of these folks are coming to us for getting their mail from us, and so those are opportunities to give them flyers and handouts, and they have really good questions. And it's just basically giving them the, listening to their needs and wants, because there's always a message in some of the conversations that they're trying to put out, and that if we're not listening to the way that they're telling their story, we're going to miss what they need. So that's probably, and Rhonda,
Yep. Well, I'm just going to piggyback on that because I think that, this is really a lot of our patients have these issues, but I think, there's several questions in the chat that are centering around compliance. And, compliance is a really, really difficult issue to deal with because the whole issue, we really practice from a model of housing first, whether it's in the respite program or whether it's COVID-19 or any other issue we deal with, substance use or whatever. But housing first means you don't, you keep them housed almost no matter what, and find the one little gem or the one little pearl that seems to be motivating to the person you're in front of. And I think that's what we do every day, whether it's COVID-19 or some other issue. that as Annette just said, they're coming to you for something, and it could be a fresh, clean pair of socks, but there's something in there that's got that person in front of you, and you use that opportunity. So if somebody goes outside and they go across the street because they're a chronic alcoholic and they're finding a way to get something to drink, but they come back in, we're going to accept them. And the idea of compliance, especially during COVID-19, we'd rather have them inside in their room than have them going back out on the street and staying back in the park. And I think that, and for some people that doesn't make sense, and I don't know why, but from a public health standpoint, that makes a huge amount of sense.
Thank you, Rhonda. And Dr. H., you had wanted to add real quick to this issue? And you may be on mute.
I'm sorry, I was. We've talked about this before. Relationship is certainly key, and I would also say that having them work with their mental health provider is very, very, very important. And one of the things that we also are seeing is, particularly with the respite clients, is a rise with them going out to use. They can't use in the building, but we have a harm reduction model here, so they can use, if they choose to go out, we just want them to come back. They can't use their drugs on site. We have what's called an amnesty locker, so they lock their drugs or alcohol up in the amnesty locker, and so that we find that is very, very helpful. And I want to share that this morning we had a young woman who didn't use the amnesty locker, and under normal circumstances we would have discharged her, but we were able to really get pretty honest with her and just to say, your health is already compromised. She's one of the folks who does not like to wear a mask, and we just said to her, if you do not get to finish your round of antibiotics, and if you catch COVID, you could die, because that's what kind of shape she's in medically. And so I would say that being very honest with folks about COVID and where they are with their own physical and mental health is really, really important.
Thank you. That's really helpful. I know we're addressing lots of different kinds of scenarios in our communities, and so here's a question that we had come into the chat box about unsheltered populations. So what about clients who are unsheltered because of behavioral health issues, and that bars them from the shelter? So that might be serious mental health issues or other behavioral health, who are unsuccessful in isolation, and then criminalizing that behavior feels like the only option. What are your thoughts about that very difficult scenario? Why don't we go back to Yakima for an initial response, and then we'll see if Bethlehem Haven wants to add in.
So we have some different models of shelter in Yakima. Oftentimes people with significant behavioral health issues don't do well in communal shelters. And depending on the level, and specifically if we're talking about in this COVID issue, that is one of the roles where our medical respite program can come into play and be successful, because we do have individual units for those folks, and we do have access to behavioral health specialists who can be directly involved with that individual. So that's one of the places that we do that hopefully can be successful and more successful than a community shelter. If somebody is breaking the law or being physically threatened, those people probably are going to go to jail, or they're going to go into an inpatient treatment facility. There are not a lot of options for people that are being physically threatening to others.
Okay. Anything to add, Dr. H. or John?
Yeah, I can add. I would second that. You know, as long as an individual is not threatening staff or other clients, we can bend over backwards to work with mental health behaviors in a variety of ways, and that does not preclude someone from coming into shelter. But, you know, the caveat is, of course, the threatening language or behaviors, which, you know, sadly, it usually does end up going down the criminal path.
Got it. So we've had another question then come into the chat, and I think this kind of gets to, even though it's specific to tobacco, I think the question can include any manner of substances that our clients use. So the question is, for clients who are COVID-19 positive and need to be isolated to recover, and they obviously cannot leave the room or the site, how do you deal with a client's tobacco addiction? Or we might even just fill in the blank. How do we deal with a client's addiction? Like when they want to leave to find cigarettes, or fill in the blank for anything, and they're refusing to use nicotine replacement products. I feel like this is really the struggle. And so just to kind of keep with our pacing, I'll turn it to Yakima first to see how you would respond to this, whether it's nicotine or alcohol or other drugs. What's your response to this?
So now, why don't you go first on this one?
Well,
if you're muted.
Yeah, this is a really hard one. When they're in our respite program, because we are experiencing this now, they are pretty compliant. They're coming not feeling very well, not really wanting to go out that much. So that's kind of usually a sign when they're really sick that they're reducing their substance use or their tobacco use while they're with us. When they start getting better, it definitely is harder for them to stay in place. And I think somebody mentioned earlier, we can't force them to stay in place, but we can educate them and give them the tools that they need so that they can understand the importance of them staying in their room and being safe, and of course keeping the community safe. In respite, we're doing all of our communication by phone, so we're able to bring them the they need in terms of food and clothing or other basic needs. You know, substance is a really hard one, but like Rhonda mentioned, we practice harm reduction. So if they are using, that's not going to be a reason that we're going to kick them out of the program or kick them out of the respite program. Most importantly, getting them connected to either virtual health services or again, working with their case manager by phone.
Great, thank you. And John or Dr. H, do you have anything to add to what Annette talked about?
No, just that we send our folks go to the hotel where the folks are COVID-19 positive.
Okay. We've got a lot rolling in here, and so I just want to move then to, I think, this balancing that a lot of people are trying to strike that right mix. So here's, I think, a common question that folks are struggling with. I agree that housing retention is an essential component of Housing First, but we are also trying to balance the individual rights of each tenant with the overall health and safety of all tenants and staff. So where we are faced with the issue of noncompliance, specifically someone who can't stay in self-quarantine due to a substance use disorder, how does the service provider or the property manager who's committed to Housing First, how do we address this when it has the possible direct negative impact on the health of others? And so this may be a different way of asking the prior question, but I do feel like we're getting a lot of questions about people trying to support individuals but being mindful of the impact on the larger program. And so knowing that there's no easy answers, again, we'll just come back to Yakima, and we'll start with you guys, and then we'll see how Pittsburgh wants to add.
Yeah, I think, this is Rhonda, I think that, I mean, that is the $64 question, no question about it. And, you know, we are fortunate in, at least in our program, that we have some options. And so we have done a couple things with some residents. As I mentioned kind of in our introduction, we have, you know, our large program, which is more congregate, but we have some of our units that are more individual units. And so with some of the more difficult clients, we do look and say, you know what, maybe this person is going to be better suited because of the risk that they do pose to others if we try to move them into an individual housing unit, an individual apartment, as opposed to in the congregate housing. And if it wasn't within our own system, you know, we have a lot of housing partners in the community. We might ask somebody else, do you have a unit that we could move this person out of our congregate unit into an individual apartment? Likewise with respite, and you know, we would move somebody out of our more congregate respite into a single individual unit if we needed to. But I think this is a time when we really have to be as creative as we can to say, let's minimize our risk, the risk for the greater community as well as the risk for the individual.
Got it. And John or Dr. H, how would you add to that?
Yeah, this question is right up my alley. I'm an ethicist by training, and so when I look at these kinds of questions, particularly, and we have talked about this here with regard to folks who refuse, and clearly people do have the right to refuse care of any kind. So whether it is wearing a mask, whether it's taking a temperature, you know, whether it is just plain doctor's care, people have the right to refuse. So what we have done, knowing that people have the right to self-determination, autonomy, but you do not have the right to put other people at risk. And so we have said that if there are folks who refuse to wear their mask or to do their temperature, we will refer them either back to where they came from, or if they're positive in any way, we'll send them to the hotel. But we've had to really, we've had to really say this is also an option because we really can't make people do anything. And yeah, I think I can leave it there.
Okay, great. And I think that is a universal struggle to try to balance these issues. Yep. That is clearly something that we're seeing in the chat box here, clearly something that just the nature of this work this is not unique.
And I had a couple of questions. Barbara, to your point, you know, when you said that it's unique, I think it's really important for us all to remember that our contexts are also very unique, you know, to each other. And, you know, it's important to do what fits for where we are. Absolutely.
We've gotten a couple of questions about some special populations, and so I'll do a combo question, just being mindful of time. We've gotten some questions about how do we respond to families who may be placed and are not adhering to self-isolation requests. And then, in addition to that, are there any suggestions for helping young people understand compliance or any ideas for how we might be able to support youth who are also having a hard time navigating quarantine and isolation? Why don't we mix it up a little bit? And Dr. H and John, why don't we start with you this time? If you've got any thoughts about how to support families or youth who are presenting specific challenges.
Yeah, Barb, we don't support, we don't serve either population. We don't serve
okay, well then. Okay, sorry about that.
That's
then
okay.
Annette or Rhonda, you might have some ideas here.
That gives us some time back.
So I think, Annette, why don't you talk about maybe what we're doing at our LGBT Youth Resource Center to try to help with the youth. Could you do that?
Sure. So one of the things that we started doing, we work really close with a drop-in center called Rod's House. It's in our community, and they also operate a shelter. But we also do a LGBTQ resource center in which many of our folks cross over who are experiencing homelessness to the Rod's House shelter program. And so one of the things, or the messages that we're getting from the youth was that it is hard to stay in place when they're used to going to places where they feel safe and that people know them and they're able to get the resources that they need when they need them. And so out of the discussion and with many of our other providers and our communications manager, we started thinking about how can we message this, or how can we develop a message that our youth will want and appreciate. So we started doing a kind of like a talk show about the topics of isolation and the signs of depression and anxiety and what to watch for. And so our therapist, Dr. Ulmer, our psychologist, for the first run that he did a recorded session that we shared within the community of the youth and then in the shelters and the space, so that they could listen to his talk, and our goal is that it be more interactive so that the youth can actually call in with questions or join in a conversation. So that's what we're gearing up to, is making it more interactive with our youth, and so hopefully that happens pretty soon. We're excited about doing that. Some of the other things that we've done is our youth that are out in the community that relied on activities that help them with stress is making activity packets for them, making them available for them to pick up at our doorstep. And it was one of the case managers made a comment that when the packets were picked up, there's the glass windows between them. It's kind of, just like what you're seeing in some photos throughout the community, is that they literally put their hands up against the glass or waved to their case manager from the car driving by. I mean, they just wanted that interaction, and so we're trying to provide it as much as we can, and at the same time trying to deliver the resources that they also need. So still doing those appointments by phone. It's been really helpful, but they understand. And yes, it is a challenge with the same population because they really miss each other and really want that contact. And so we're getting ideas from them, working through a calendar of events and incorporating the virtual messaging that we're developing.
Thank you. I'm again mindful of time, and there's so many questions that people are asking, so we'll just keep plunging along. What strategies have you seen work best for partnering with public transit systems to support unsheltered individuals who refuse care and would rather stay in transit stations or vehicles? So how would you respond to that? And Dr. T or John, why don't we start with you first, since you don't serve kids, so you didn't get a chance to get first crack at the last question.
Go ahead, it's not on mute.
Hi, this is John. Yeah, I really can't speak to that question very much. I don't know how much of an issue that is in Pittsburgh of people staying in transit stations. I think Port Authority, police here in the area are pretty strict about preventing that from happening. So I don't think unsheltered individuals have used that as a strategy to stay off the streets here in Pittsburgh for quite some time.
Okay. Is this an issue that you've seen in Yakima, Annette or Rhonda?
We don't have a transit station, so I don't think we do.
Okay. All right, well then we will table the transportation piece for another time. Let's see, we'll turn to a couple of other questions. Let's see, how would you respond to giving information to people who can't read and for limited literacy clients? Is there any way that you would approach working with folks where the written materials that we're providing to folks just may not be the best way for them to get information?
I can speak to that a little bit. We just try and repeat the information verbally on a daily basis. I mean, we do obviously have handouts and signage up everywhere, but myself and my staff included, you know, it sometimes feels like we're just repeating ourselves ad nauseum, but I think that is, you know, not only does it reinforce the important topic, but it would help for those who have trouble reading as well.
Got it. And anything to add to that, Rhonda or Annette?
I would agree with the repeating the message over, and we know, and some of the examples that I can give that it's working is because they'll say, we know we're the most vulnerable population, and then they'll also ask us about hand washing videos. So we had an individual come to the counter and demonstrate that he had just watched a video on hand washing and stood there in front of our window and showed us his hand washing technique. So we gave him lots of praise on that. We also rely on flyers with pictures so that if they have questions, but again, just I would agree is repeating the message as often as we can, because we know that if they take the message and deliver it to a few other people, that's going to help. That's going to help.
Got it. We're coming down to our last few minutes, and so let's just try to squeeze in one more question here. And I think this is a common one. How do you encourage clients to wear a mask? And what are you doing to protect staff when they don't? And so I imagine the wearing of a mask issue is going to probably be a conflict point, particularly in a lot of congregate settings. Who wants to start on what suggestions they would have there to encourage clients to wear a mask?
You know, I just always have my brown bag with masks in it at the ready, because it's constantly an issue with clients not wearing them. So, you know, every time I walk through the room and someone's not wearing a mask, I just hand them a new one and, you know, try and do more education and encouragement. And I really don't know what else to do at this point, but a lot of clients seem to have gotten better at and more comfortable wearing the masks as time goes on and the message gets clearer around this issue. But thankfully we have a really good supply of masks, so I don't feel restricted in any way. I'll just keep on handing them out.
Got it. Rhonda or Annette, thoughts on that?
I'll defer to Annette on this one.
I think we're doing a lot of the same things, just encouraging them to wear the masks. We keep them available. Right now, with the limited supply for us, we are offering an alternate mask. So some of the homemade masks, I think that that they might be more willing to even wear. We've heard comments like, "Oh, that mask looks cool." So making things that getting masks that and allowing them to pick out something that they might like will hopefully help them or encourage them to wear their mask more often. We haven't had a whole lot of resistance in our congregate housing. They understand the importance. It's after they leave the building, but I think, again, repeating the message of why they need to wear it no matter where they go, I think is important. So I think that we've definitely had more success. And I think because our clinic services are in a pretty much a 2-3 block radius, that our healthcare centers, they see the staff also at the entrances, and I think it sends more of a message of urgency, so they will ask for them on their own even if they don't have one.
Got it. I know we are at time. I just want to point out a number of webinars that we have on the immediate horizon, particularly 3 next week. If you are interested in this topic, then you will be interested in Tuesday's webinar on delivering health care in isolation and quarantine facilities. And I know domestic violence and testing both have been issues, and so we've got those on the horizon. You can get the registration links in the resources box below. And I just want to double back and say thank you so much to our friends in Yakima, Rhonda Hauff and Annette Rodriguez, and our friends in Bethlehem Haven and Pittsburgh, Sharon Higginbotham and John Strong. Thank you so much for sharing your expertise, your experiences with us. This is a very crazy and unique time. We are all figuring our way through this. And so just thank you for being here today to help us with this discussion. We will be having more, and no doubt as this issue evolves, more issues will be arising, and we will continue gathering to share our community's experiences.
Yeah, thank you for having us.
Thank you. Absolutely. And I'll draw folks' attention to some more resources that we have at the National Healthcare for the Homeless Council, to include our TA page. If you have resources, please share them with our TA manager, Michael Durham. And on Wednesdays, we have regular issues coming out of our solidarity. And then at the end of the month, we have our Action Alert Mobilizer. So thank you, everyone, for joining us today. We know how precious your time is right now. We know that these are important issues. And so we wish you the best of luck in supporting all of your clients and really trying to do the best we can in a very hectic time. So with that, I will close out this today's discussion. There will be an evaluation that pops up after this. Please let us know how we can be improving these discussions, or if there's other topics you'd like to see us have. And with that, I will say goodbye and best of luck to everyone. Thank you.